explosions are the main cause of combat burns. 1 in 10 war casualties is a burn victim. Half of all burn victims also have penetrating trauma. That is why combat burns are more serious than burns in the civilian context. Ground war results in 2 situations typical of explosion burns. A soldier on foot has superficial burns on exposed areas, hands and face. A soldier in a vehicle has deep burns concerning more body surface area and respiratory damage. Obviously, serious burns hide associated injuries. Burns kill, but more slowly than hemorrhage and suffocation. A burn victim should therefore be assessed systematically like any war casualty. In addition to associated injuries, the body surface burned, the burn degrees, and the location, hands or face, determine the severity. The surface area burned is estimated by dividing the body into eighths, front and back, then upper and lower, then left and right. Prior to tactical security, no rescue action is specific to burn victims. Damage control for associated injuries is always the top priority. The severity of the burns determines the imperatives of the initial intensive care. If a quarter or more of the body surface is burned, loss of plasma requires fluid replacement infusion. When half or more of the body surface is burned, intubation is necessary to prevent obstruction of the airways. Intensive care for the severely burned patient consists of transfusion until blood loss is under control. It continues with transfusions of plasma and crystalloids. Initial surgery on associated injuries is not changed by the burns. Burn treatment is a combination of intensive care, repeated surgery to perform debridement and skin grafts, wound dressing under anesthesia, fighting infection, and rehabilitation. It requires significant resources in terms of personnel and equipment. Rapid evacuation to a burn center is therefore essential to optimize the patient's future and to avoid saturating facilities upstream. This challenge is magnified by an influx of patients because combat burns often involve several casualties at once. The amount of body area burned, the main triage criteria specific to burn victims. Combat burns may also occur in civilian practice. Terrorist bombings cause an influx of burn victims comparable to the one in a war situation with the associated trauma. Burn centers are rare, and their limited capacity means they are quickly saturated. Other emergency and intensive care centers must be able to treat patients with acute burns in the beginning. In the absence of facility combining urgent traumatology and burn treatment, urgent traumatology is the top priority. Treatment of acute burns, especially with associated injuries, is an essential military skill that must also benefit the general public.